PACS which is available outside of radiology. So people can access from the departments. So the doctors who have actually ordered for these tests to be done. So we have an oncologist who has requested for, let's say, a mammogram and an ultrasound to be there, or the pathologist basically looks at the results of that to decide whether an FNAC needs to be done or not. So at least it has reached that level now. The fourth level is basically entire CPOE, clinical decision support, including clinical protocols. So there are pathways which are available, protocols which are available. So if we have a patient, let's say a 40-year-old patient with an acute myocardial infarction who comes into the hospital, no diabetes, no hypertension, so do not assume any complications. A CABG is going to be conducted on the patient. So on day one, who are the different people who are going to meet up? What are the orders that are going to be placed? On the day, second day, which is the day of surgery, third day, day of post-operative, day one, day of discharge. Who are the different actors? What needs to happen? What medications? Anything that's going to be used is actually documented as a part of the protocol, and the system actually follows that. So if someone misses out something, then there are alerts which automatically come in the system, workflows come up, people are alerted, they don't take any action, it gets escalated, and so on and so forth. Stage 5, you have a full radiology PACS across all the departments, whether it's from an ophthalmology, whether it's an oncology PACS, whether it's radiology PACS and everything out there. Stage 6, physician documentation, including structured templates, order sets, full CDSS, including variation and compliance, closed loop medication administration. All of these features are available. This itself is a huge topic by itself, so I'm really going to rush through. Stage 7, which is like the final kind of vision where people would want to reach. There are hospitals in the US which have achieved that. There are hospitals in APAC which have achieved that. Complete EMR, the CCD, the continuity of care document transitions to shared data seamlessly, data warehousing, analytics, data continuity with emergency department, ambulatory, OP is available. So those are the details that are there, and the slides will be, these presentations will be available, at least some of the presentations will be available for you on our website, so you can actually download from there. So a lot of predictive models. I mean, the world's moving towards analytics, right? We spoke about this yesterday very briefly. So we're going to have injury prevention models, so infection-related models, falls, trauma cases, glycemic control, adverse drug events, predicting things before they are occurring, or at least to an extent where what are the challenges that you might face out there. Atrial fibrillation, so based upon patient monitoring devices. So yesterday, Dr. Divan talked about Philips system. So VisiQ is a great system that's there. So it has the ability to say for an intensivist which systems that which are the patients that you can that you need to really concentrate upon right now. So predictive models have been there. It's not that it's really a new thing. They've been in existence for 10, 15 years. So moving from simple statistical, stochastic models to machine learning, deep learning, heuristic, algorithmic models is where we are moving to. And I'm sure a bunch of organizations here are working on that. So across the areas, so these are some of the models which are available today that hospitals can imbibe, clinicians can imbibe. It's basically a tool to assess them. And the amount of information today the clinicians are having is humongous. And it's just not possible to look at that information. So some of the things from a revenue and operational perspective that exist is that campaigns, right? Hospitals run campaigns. And how do you run a campaign? So, next month is World Cardiac Day, so I'm going to do a cardiac campaign. Or there are very specific campaigns. I mean, if you look at really retail, banking, and other sectors, those so specific campaigns, right? You look at Flipkart and how it actually does it, or an Ola Caps, or any of these guys. So basically, can you look at a patient who had a transient ischemic attack and who had an MRI brain? So the radiology report, you apply natural language processing and that, and see which of those patients actually have an aneurysm. So based upon that, now you have a bunch of patients, so let's say 1 in every 10 patients have an aneurysm in those MRI brain cases, then those patients need a digital subtraction angiography, a ballooning to be done. So it's a very specific campaign that can be done basically using these models. Revenue cycle predictive analytics, and a whole lot of them, activity-based costing, which I'm sure most of the hospitals will be interested in. Details from a population health management, data aggregation, so which we have spoken about. So Jay Seelan yesterday was talking about it. Risk stratification, care coordination, but more importantly, patient outreach. So there is an amazing work that's happening by Madhu from MQR. I'm sure she spoke about it yesterday. There's a great work that's happening in terms of outreach. So those are some of the things that exist. So again, some screens, how do your risk models come up, how predictive models actually show up those risk scores out there, how you can actually take, so this is a data taken only from Pune where there's a huge amount of information, and just taking a hemogram value, saying that which of the patients are actually anemic, who have the potential, based on the PSA values, who would get, or who have a higher risk of prostate cancer, who do not have a risk of prostate cancer. So basically looking at those information, so the orange guys are the ones who have the risk rates over here. And just taking a diabetic patient based upon these best practices going forward, like what are the different things that you can do? So when would the patient potentially get a nephropathy, neuropathy, retinopathy, and so on and so forth is something that you can actually do. So these are some of the best practices that we have seen that are being implemented across hospitals globally. Thank you so much.
Thank you, Mr. Vamsi, for explaining the stage EMR's adoption model. I would like to request Dr. Gogia to take it over and explain us like how we kind of mitigate the natural disasters with the help of IT.
Thank you. Actually, my talk is a little bit of an anomaly here because it's about doctors more out of the patients rather than doctors and getting outcomes. And anyway, let's see where it merges into the current topic. 70% of healthcare is private. Most of the solutions which you talk about, of course, are either in the corporate level, which is again not a very other, because most 60% of patients are rural based. You know, when you talk about the high-end solutions, we are looking at very, very low-end solutions are required. And actually, if you work in a rural area, whom does one go to? How many of you have ever stayed in a rural area? We would just be interested to know. And when you had a problem, who was the doctor you went to? I mean, in your old days, of course, not now. The local doctor who is the RMP or the quack or whatever, right? And also another thing which I would just like to state is telemedicine, which has been talked about yesterday. I say very clearly it provides half a doctor. But if we use the rural doctor who is already there, enhance his skill level, can we make it more than half? And we say telemedicine is good where there is no doctor because the half a doctor is there. It is useless where there is a 100% doctor. If you have a hospital next door, would you try to do telemedicine? You won't, because you got a good doctor with him. This thing is that whenever a problem occurs, like a disaster, like we show out here, or people in this thing, when they face with a problem, how can they get quickly, with the help of IT, the support they require? And just take another example of it. A local practitioner, again in the rural area, a simple dressing is required. But one of the components of the proper dressing is missing. It can be knowledge, it can be equipment, or just the drugs. Now, these things can easily be sent. The thing that we are going to transmit through telemedicine is the knowledge. And with that, we can improve healthcare and things. Otherwise, that 20 rupees turns to 2,000 rupees or so, and this has all been discussed yesterday, so I don't want to go too much into that. And based on these is some of the projects that I'm talking about are being discussed. We have done a project in Mizoram where, I mean, this has been the same as the Arvind Eye Care model, a little different. I don't want to go into the difference, we don't have the time. But in that project, which is basically trained people in the block level who are not doctors, who are at fixed centers. They have seen over 10,000 patients in 2 years, and we have showcased there has been huge saving in the cost of transport, and it has more than paid for itself. The project cost has been paid for just by the saving that we created in that. Similarly, another project, I don't want to spend too much time on this because it's a limited time. I was told 4 minutes actually, so I don't want to spend too much time on all my this thing. Another topic, which is again close to my heart, a problem in the rural areas. There are 40 million patients of lymphedema in the country, 40 million, mostly in rural areas, and they require very, very simple care. Leg washing, sometimes antibiotics, massage, compression therapy, and you can do that at the village level. 90% of care is possible at the village level. The only thing missing, unfortunately, that missing element is not only among the doctors, among the rural practitioners, it is also missing among the doctors in very, very high-flown areas. In the corporate, they don't know that lymphedema is a treatable problem caused by filariasis, sometimes after cancer. It is a very well treatable problem, but just the knowledge is missing. And through telemedicine, we want to just get that knowledge simulated, get the equipment sent across to those places, and a huge patient load of the second or third highest cause of morbidity in India can be controlled. And telemedicine, again, is a facilitator for that. Just improve the knowledge level of the people in the rural areas and give them the components that are required for that. Similarly, Nepal has had a disaster, and it's well known that 80% of the population gets affected by the disaster by mental problems. 3 to 5% of them turn serious over a period of time, over a few months. And for that, long-term and monitoring and care is required, which is best done at the community level. The local people are the best people to do it. They just need a little bit of training. And we had done a similar project after the tsunami and found excellent results. We could cut down the suicide rates. Similarly, the suicide rates in Nepal have gone down to a huge extent. And we are trying this project. And this is the summary plan of a project. We have done a needs assessment. We have identified the problem areas where the 90 to 80% of the houses have been destroyed. There are people who are almost still 10% of the population affected. We have identified the local partners who can be trained. We have looked at the availability of connectivity. And then now we are well into the implementation phase. We have to order the necessary equipment, get the funds. Of course, we are looking for funds to help us partner the project. Installation training, do the test sessions. We have already identified an expert partner, which is the Dharan institution, which is one of the, like the aims of India is in a place called Dharan. And their psychiatrists have been identified, and they are willing to participate. Then we do the maintenance, troubleshooting, retraining of the people, how to take care of, see the psychiatrists are sending across their own people to train the local workers on how to identify the serious problem people. They are brought to the center, and a teleconsultation session takes place at an appointment time. Then we do the documentation and we hand it over to the partners who are looking into it. So, in summary, I would just put some phrases. There is a thing known as Andho Mein Kana Raja, and all of those who don't know Hindi, it means for the one-eyed, for the blind, the one-eyed is king. And for us, the rural practitioners are the one-eyed people. Let us enhance the skill levels, let us enhance their vision so that they can do better care. Also, if we do that, the jobs will remain in the rural areas, and it will help India to attain the 8 to 10% of growth. IT has to be facilitator where the knowledge is the big gap, and let us focus on the people's needs, and solutions will automatically flow. And when we do that, you have to send some equipment and knowledge across. Thank you.
Thank you, Dr. Gogia, for sharing your wonderful work in the disaster mitigation area with the help of IT. Thank you so much. We know that there is a really low doctor-to-patient ratio, and training paramedics would definitely help in increasing the reach of the patient care in the rural areas. Thank you, Dr. Gogia. I would now request Mr. Anand Ambekar to take it over.
Good morning, everyone. So I represent EMC Square here. So first of all, some introduction to EMC Square and why we are here. So EMC is a federation of companies. We provide storage and cloud and virtualization infrastructure to IT services, and all over the world we have, we have the cloud providers, and we are known for the infrastructure providers for all the financials, healthcare, and insurance players all over the world. We also have as part of our company, we also have RSA in our portfolio, which is focused on security, data security, and IT security. And we also, basically work with healthcare providers all over the world to make their IT applications work seamlessly behind the scene. So that is about EMC. As a EMC in India, we started with a vision to transform healthcare in emerging countries. So what we mean by that is more of, we don't want to play into the healthcare IT ecosystem itself, but we want to enable the players, the IT solution providers, to come on a platform. And we strongly believe that no single entity can, transform the healthcare. But we believe that a platform wherein all the players coming together and solving the healthcare problem does make sense. So, so we set out on building the platform with all the entities tying together, and so the solution or the platform concept was more of building an integrated and interoperable solution, and we believe that so the integrated and interoperable solution can work when all the ecosystem players are tied up onto the platform. To show the power of platform, we started out our journey with public health solution. So Dr. Balaji set out a context about taking care of health workers, what they do on the ground, and how they deliver healthcare delivery on the ground. So we thought let's focus on the public health and how do we transform the public health delivery at the ground. And so we developed an application which is based on this platform and which makes use of this platform to basically create universal health records for the citizens, healthcare mobile applications for health workers, ANMs and ASHA and male health workers. And we also provide a doctor's portal who is working at PHC to monitor and understand the performance of health workers and the actual ground realities of the healthcare delivery. Then we have public health management as one of our consumer, wherein the professionals will look at the dashboards, understand the PHC management, understand the PHC work function and operational efficiencies, and we also come up with the dashboards for them to monitor those things. So some of the applications, so the application which is built on this platform is basically giving the government a complete understanding of primary healthcare delivery at PHC level. So this can be scaled up at the state level, at the national level as well. So we have covered, this is a very comprehensive application we have developed on top of platform, which cares about NCDs as well as communicable diseases, and more emphasis on RCH is also given as government is also emphasizing more on the RCH services. So when a patient at a PHC or at a subcenter level, when a health worker visits a patient or a citizen to monitor his or her health, currently they carry at least 50 number of registers with them, with huge registers, and they do maintain all those paper records and do create all those monthly and weekly reports. And that is a huge burden on them in addition to the care delivery that they are providing right now. So we set out our journey to basically digitize all these processes. And this is a pilot, this is basically piloting in one of the PHC in Karnataka. And so these are the dashboards that we have for ANMs, for the health workers, and to see basically how she is doing and what all activities that are upcoming for the next week and next month. So this is more of increasing health workers' efficiency, increasing the PHC healthcare delivery efficiency, and as well as monitoring the performance of the entire healthcare delivery system. So since government has a strong emphasis on RCH, so we have these individual registers which are digitized, which includes maternal health, child health, reproductive health, child nutrition, as well as communicable and non-communicable diseases. So that includes including the immunization charts, then growth charts, and then basically TB treatment, how the treatment is delivered, dermatology functions, these images shows where there are problems, what kind of detailed patches, and so on and so forth. We also have the screening, oral cancer screening camps, which basically a PHC carries out in the catchment area, and it basically screens for the possible cancer patients and report it back to the PHC and state level departments. We also incorporated a module wherein citizens of the catchment will provide feedback on ASHA or health workers' performance. Are they happy with the performance? What kind of problems they are facing? And so we talked about sensors earlier. We have incorporated and implemented the wireless Bluetooth-enabled sensors in this whole system, where healthcare provider or healthcare worker will measure 6 parameters of the patient, and without entering into the system, it directly delivers to the patient's medical record. So we have almost 6 or 7 parameters, vital parameters, which we capture into the electronic medical record of the patient. On the doctor side, we have provided a portal for the doctor wherein a doctor can do OPD of a patient when she or he visits PHC, as well as take the baseline health and understand the health indicator dashboards, how the PHC is doing. There are some graph related information